Thank you very much. The only bad news is that in Italy now is dinner time, so I'm kind of sad to upset my colleagues and my friends in here who has to have dinner in front of a screen while we're talking about fistula. But it is what it is. So thank you again for having me. It's great to talk about this great topic between friends, I would say. So I will try to keep this part a little bit informal so you don't get bored. So since the very first slide, I think you can realize how much I care about Her Majesty, postoperative pancreatic fistula. I'm going to focus more about how to predict and mitigate such a thing, while then it will be a matter of Keith to teach us how to be better surgeons. So I will do the easy part. So Her Majesty fistula. I mean, I love the title that you chose for me, because to predict and mitigate something, basically it means that we cannot avoid having a fistula. So basically the fact that we are facing that fistula is there and unfortunately is here to stay. So we're going to try to predict and mitigate such a thing. And we're going to start from some high level evidence, okay, that I took from a very famous TV series since the last decade. So let's learn from this high level evidence.
Eli, I need another sample of Mr. Rabb's fluid.
Oh, that's going to be tough. I took the drain out.
You what?
No, with the drain in, he can't turn over, which means he has to sleep on his back, which means he isn't sleeping. So.
Okay, just call radiology. We have to put it back in. They need to be able to see the fluid to tell if there's an infection.
Well, I can tell by looking at it that it's not infected.
Just call radiology.
Look, if Dr. Bailey wants to put it back in, then I will.
No, she's in surgery.
Well, then it'll have to wait.
Well, he's right. Patient records for the past 3 months show a post-op complication rate way lower than the norm.
Wait, 12% compared to 42%?
Yeah.
Wow. Okay, can you two stop being impressed by him? It's a fluke. He's mean.
Hand me those charts. I think he's kind of hot. Can you say that about a nurse?
No.
Day 3. Day 3.
A bracelet with his name on it.
Hey, if we remove the drain on day 3 instead of day 5, we can reduce the formation of fistulas by 30%. Miranda Bailey is going to cure fistula.
Okay, so looks like we're dealing here with such a hot topic, okay? Because even Grey's Anatomy tackled this in one of, of his stories. But I mean, this is just to, keep in mind how huge is this issue we're going to tackle. So going back to our webinar, I think that we cannot avoid talking about how to define such a complication, because to define something, I think this is a great example on how we need to talk the same language in order then to tackle this issue altogether, because it sounds crazy how back in the day, before 2005, several, I would say dozens of different definitions of fistula existed. So it was by definition impossible even to compare outcomes between centers and surgeons. So can you realize how impossible it was at that time to try to find a solution for such an issue? So this was, of course, done by the ISGPF at that time, with a definition of fistula, which is now in the books. I'm not going to stop here. I just want to highlight how this definition also provided some grades, which were the A, the B, and the C. It became, over the year, I would say, a trademark of the ISGPS. But this is important because it's important to show once a definition and a complication might either be clinically relevant or non-relevant. This is very important for surgeons. And of course, this definition was not perfect. It was known since the very beginning, but without a definition, it was impossible to start to assess things the same way. Which were the criticism at that time? Well, the first one was that the concept of non-clinically relevant made the grade A more similar to the non-fistula world than to the fistula world. And then also the clinically relevant thing was actually kind of tricky, because at that time, we were not so, let's say, familiar with percutaneous drainage, angiography, endoscopic procedures. So the border between B and C was actually not so clear at that time. So that's the reason why 11 years after, fistula was redefined, again by the ISGPS, that now whenever we deal with the fistula, by definition, we are defining a clinically relevant entity. So we have now a biochemical entity, which was the former grade A, and also, I would say, a more defined border between B and C, with all these minimally invasive, we can say, so endoscopic percutaneous procedure pertaining to the B world. While we mean with a C-grade fistula only once pre-operation, organ failure, or death occur. So now that things are clearly, and of course we had a drop in the overall rate of fistula according to the new definition, and we have now a broader, I would say, entity, which is the grade B, while grade C is actually less frequent, but I would say more relevant, also in terms of cost, because these patients are mostly managed in the ICU. I think we're now ready to start talking about how to prevent and how to mitigate such an entity. So we're basically dealing here with the preoperatively and the intraoperatively setting, while it will be, I would say, Keith's task to then show us what to do after surgery. So I'm going to start, well, first of all, telling you that the good news is that no more classification so far in grading, but the bad news is that still we're dealing with a major outcome determinant, because we all face fistula, not only in Grey's Anatomy, but in our everyday practice. And starting from the preoperative setting, we are now able to define a risk based on such parameters that we defined in this recent publication, which is very important in some, I would say, specific scenario. You can see here that in this model, which is, I would say, pretty easy, we are also able to define that in this fork, the duct size and BMI already define a risk of fistula even before the operating room. And why this is important? Well, this is important because whenever we face entities like cystic neoplasm of the pancreas or neuroendocrine tumor, basically those entities in which we have to scale the pros and the cons of doing a Whipple, then the risk assessment, starting even from the preoperative setting, might be a factor in the equation that we want to keep into account. And of course, by improving the patient selection and the counseling, we can also already define our decision making. We can, of course, define whether to apply or not ERAS protocols or other studies that we have. It's starting since the very beginning to be a crucial aspect to define whether a patient is more likely to develop a fistula. And this concept will remain until the entire time in the operating room and day after day until the fistula eventually take place. So this is a very important concept I would like to stress. And this is nice that, as in a relay between the preoperative and the intraoperative setting, the definition preoperatively, you see here, it's the same that we find then in the intraoperative setting. I'm going to talk now in a minute about the fistula risk score. You see that all the preoperative assessment as a low risk are, you see here, found in either negligible or the low risk zone, while the patients who are already at higher risk in the preoperative setting are now in the intraoperative setting in the area at higher risk of developing a fistula. So we're getting now closer to the eventual fistula formation, and even our ability in defining the risk become, you will see, better. But let's go back a little bit into the definition world. Why I was so concerned about the definition? Because when we all, I would say, keep in mind to consider the use of some device, some tools in order to reduce the occurrence of fistula, this Cochrane review actually focused on somatostatin analogs, which were used in Verona till some years ago. And in this review, the overall rate of fistula was actually decreased by the use of somatostatin analogs. However, when we go to the actual data, you see that the actual decrease of fistula was found with the use of octreotide only in the biochemical ones. So if we go to the actual data regarding the risk assessment, the use of prophylactic octreotide is not useful. Actually, in those patients at higher risk for developing a fistula, the use of prophylactic octreotide is actually detrimental. So once again, to define a complication and to grade a complication is of massive importance to define our management. So now we finally move in the operating room. And this fistula risk score has now been incorporated in the surgical practice of many centers all around the world. You see here that we have some factors, namely how the gland looks like, either firm or soft, the pathology while we're operating on a patient, again, duct size, and the intraoperative blood loss. We can discuss about the reliability, but still this is a surrogate of how tough the surgery is. So based on these risk factors, you can define whether your patient is at a higher or lower risk to eventually develop a fistula. And we see now why this is so important. So we start from the negligible risk group. Those are the haired pancreas with a big duct. Those anastomoses are the one we love to do. It's great, to have residents starting to do this anastomosis. In this case, once you assess that the risk is almost zero, you can even consider to avoid placing drains, which is something that was, I would say, kind of crazy 10 years ago. But we found that once we apply this drainless policy in the negligible fistula risk zone, you see that the risk of fistula is actually zero. So the use of drain could be even detrimental in these patients because it's mainly a way for bacteria to come into your fluid collection rather than protecting from a fistula. So again, this is very important because at that time there was a big debate, particularly triggered by the trial by Van Buren, published in Annals of Surgery, in which drainless policies were associated with high rates of mortality. And the reason is because at that time there was no risk assessment. So in this setting, of course, it sounds now absolutely not reliable to avoid putting any drain no matter what, meaning in a pancreas without risk assessment. So as a landmark, we now can apply a selective drain placement policy depending on the fistula risk zone assessed once in the operating room. So we now move into this, I would say, wider group of either low or intermediate risk of fistula. And in this case, what we follow is a policy named early drain removal, meaning that once we put drain, we can, by testing the amylase, decide when to remove the drains, but that's another story, and this is going to be, I would say, the topic of the next presentation by Professor Roberts, so I'm not going to go through that. But I want to spend a couple of words regarding the high risk zone, because in this case is where the mitigation strategy became protagonistic. We ran a trial, a randomized controlled trial, a phase 3 randomized controlled trial published in JAMA Surgery 3 years ago on the optimal management of this horrible pancreas. So those are only the soft pancreas with a small duct. And in this case, we wanted to challenge which was the best anastomosis in between the PJ and the pancreogastrostomy, which was, I think, very, I would say, fancy at that time, at least in Verona. All cases, you see, were mitigated because it was already clear from retrospective data that in this case, it was better to put an external stent in order to mitigate the formation of a fistula. As expected, we didn't find in the trial a significant difference in terms of fistula rate, but the burden, the fistula clinical burden was actually lower with the PJ anastomosis. So at that time, we defined that this was, in our experience, the best way to mitigate the potential formation of a fistula when dealing with a horrible pancreas. A word of caution should be used regarding stents, because either they are internal or external. We prefer the external one because we can see the actual fluid draining out. You see that there is an advantage in putting a stent whenever the fistula risk score is between 7 and 10. But as I said, the stent needs to work properly, because once we face either an occlusion or a displacement of such a tool, you see that the outcome were as bad as when we didn't put any stent, or even worse. And I'm going to show you why in a couple of slides. So be careful about the technique you are using to secure your stent, because you really want this tool to be in place and working. Otherwise, we can be in trouble. So again, another landmark was that when we're dealing with the high-risk cases, a PJ with an external stent was our choice once in the operating room to either prevent or mitigate a fistula formation. But we want to do better. So as I showed you before, one of our major issues was the potential dislocation of the stent. We are now using Pancreas-specific tools, which are actually way better than those that we used back in the day. But we are even trying now with this pilot series coronary artery stent in order to secure our anastomosis. This is, I would say, a very fascinating way to try to tackle this issue. I'm going to show you how. So basically, I'm sorry about the low quality of the video, but this is truly experimental. We put the stent, which of course, by expanding in the main pancreatic duct, is able to be really shaped the way we need it. And once the stent is in, we then perform the anastomosis. So once again, this is totally experimental, but I wanted to show you this because it's a way we are now testing to define would say, an optimal way to drain our anastomosis and to have a stent which is really suitable for the specific pancreas we are dealing with. So I don't have definite data, this is just a pilot series, but the preliminary data shows us that the dislocation could be extremely low. So we'll see maybe in the next future what data will come. So this is, I would say, the final slide in terms of conceptual framework for a risk-based drain management. So everything starts, we see it before the operating room. So we are now able to define the risk of a patient even before going to the operating room. But then, the more we move closer to the fistula, which can take place by definition since POD3, we are, as I said before, more able to define the risk of the specific case we're dealing with. So once in the operating room, we always assess the fistula risk score. And then at this point, we decide whether to put or not drains. Because as I showed you, when the risk is negligible, drain can be even detrimental. And if we put drain, we start testing the amylase level. And the amylase level are the main driver of these policies, which are, as I said before, the early drain removal policy, depending on the value. But please, again, be ready to change your practice. Because, for example, if you decide to put a stent, the same amylase threshold lose their way to be reliable tools. So we always have to update our risk estimate depending on the specific case. And I want to bring your attention here now on POD1, because it looks like we have now a new kid on the block in terms of complication after surgery, because you know that the ISGPS has now defined the occurrence of pancreatitis taking place after a pancreatectomy. The name is PPAP, post-pancreatectomy acute pancreatitis. Why is that important? Because once pancreatitis takes place, this could serve as an early trigger of fistula. So you can realize that we are now in the very early postoperative setting. So if we are able to define the patients who are at higher risk of developing acute pancreatitis, our capability to define the risk of fistula in this very early period could be even better. So you see how this capability updates itself in terms of predicting a fistula, and I could, predict that the postoperative acute pancreatitis is here to stay because it will help us in refining our way to define the definition of a fistula. This is my slide, and this is the concept I want to leave you with. So if you now all agree with me that fistula will always be, unfortunately, a protagonist of our clinical practice, I think that in this journey throughout the decade, we're now getting better and better in predicting fistula occurrence, but there will always be, as in a bottleneck, a rate of patient, a rate of pancreas that will eventually leak. So I think, and I'm curious to get to know your opinion in this regard, that we have now to shift between a prevention in the fistula to a mitigation of a fistula, because you know that in some case, leak will take place. So what do I mean with mitigation? Well, I mean that now in the toolbox of a pancreatic surgeon, to avoid using the octreotide, to keep in mind that you can place phalangogynostomy if you realize that the patient is at higher risk, to use the anastomosis you trust the most, which in Verona is the PJ with an external stent, to test your amylase, to manage your drain accordingly, and to study, as I just said, the occurrence of PPAP will serve as the best way to mitigate this leak and, at the end of the day, to be better surgeons for our patients. So I think it's now time for me to pass the microphone to Keith, and I hope this served as a good introduction to the paranoia study that we all know about. Thank you very much, and I look forward for a great debate together.